Good morning and welcome to this webinar. My name's Diana Naehrig, and I'd really like to welcome you to our webinar series from the living room at the Chris O'Brien Lifehouse in Sydney, Australia. Today I am joined by Henry Woo and Emma Wong, and we will be talking about living well with cancer, not just living well, but thriving with prostate cancer. So before we get started, I think it would be good if we would introduce ourselves. So perhaps ladies first. Emma, can I ask you to tell us a little bit about yourself and your work here at the living room? Thank you.
Okay, so thank you so much for having me this morning. It's actually such a pleasure to join and have this discussion today. Such an interesting topic, and it's one that I get asked really often. How did I end up researching in prostate cancer care? So I just give you a little bit of a background about myself. I am a practitioner of Chinese medicine. I was asked some years ago to present a casual lecture series to nursing staff and some medical staff about Chinese medicine and cancer care. And during that time, I was referred some patients to private practice through my teaching, and at one stage was seeing quite a few men with prostate cancer and on different parts of their prostate cancer journey. And it was also at that point I was so kind of moved by what these guys were going through that something I've never actually done before is that I went home to all the men in my family and I said to them, look, you guys really should get your PSA tested. Not that they had any family history that I knew of or any symptoms. And anyway, the result of this was that a young member of my family was diagnosed after a period of months of testing, was diagnosed with a Gleason 9 prostate cancer, which is an aggressive prostate cancer. So it was at this point that I guess my interest in research and a sort of personal motivation came to light. And I then started to really look into how could I help? How could we make a difference with Chinese medicine and really namely acupuncture and electro acupuncture for recovery after radical prostatectomy. So here I am. I'm now doing a PhD and I'm looking into trying to improve outcomes for men after radical prostatectomy. And I'm also really interested in how integrative oncology can help in prostate cancer care. And so today, when I get to my part of the presentation, I'm going to try and just tread that tenuous path of sharing with you some information as a researcher and also sharing some information as someone who's been a support person. And hopefully that can help anyone who's listening or just shed some light on and just sort of, you know, we can have a kind of easy discussion about things that happen during the prostate cancer journey and the things that we can help to really get you, anyone who's going through prostate cancer right now to help you live your best life. So that's me, and I'll just pass over to Henry.
Hi, I'm Henry Woo. I'm a urological surgeon, and I'm a little bit different in my work as a urological surgeon because I'm very subspecialized, and it might sound boring to some people, but all I do is just prostate, work with the prostate. So that means I don't do work with, you know, urinary bladders or kidneys or testicles or other conditions like that. Just good old prostate. I'm also an academic surgeon, which means that I'm, you know, constantly involved in research pursuits, always looking to see, is there something that we can do better? And so with that academic interest, I hold an academic appointment at the University of Sydney, where I'm a professor of surgery, and I'm also He's director of the Uro-Oncology Department at the Chris O'Brien Lifehouse.
Wonderful. Thank you very much for your introductions. So what we're going to do today is first Henry will talk to us a bit about all things prostate from his perspective, and then Emma will present on some of the integrative and complementary treatment modalities for people with prostate cancer. And after that, we'll have some time, hopefully, that we can answer any questions that there might be. So if you do have any questions that come up during the presentations or things you've always wanted to know about prostate cancer and its treatment, please feel free to use the chat or the Q&A function on the bottom part of the screen, and we'll do our very best to look at those questions and answer those for you. So thank you, and without further ado, I'll pass on to Henry.
All right, thank you very much. Look, I thought that what would be of interest is just to take our audience through what a typical prostate cancer surgical journey might be. And it's a very contemporary look at it because things have certainly changed quite a great deal over the last 5 to 10 years. Now, the typical presentation, how does a patient come to me and end up having prostate cancer? The usual presentation is somebody will have an abnormal PSA blood test result, and so the levels might be higher than what would normally be expected. But quite commonly, in fact increasingly, we're seeing men where their PSA blood test levels, prostate-specific antigen blood test levels, are actually normal, but what's been observed has been a progressive increase over a period of time at a rate that will be a little quicker than we would expect for the aging process. A very small number of men will come to you because their general practitioners have found an abnormal feeling prostate when they were examined. And what is becoming, and what is also a very uncommon presentation is where it's an incidental suggestion of a prostate cancer diagnosis when tests are being done for something else completely unrelated. So, for example, if they happen to be having an MRI scan for something else and included the prostate in the field, and they saw something that looked a little bit unusual, that could be a mechanism by which they enter into this journey. Once we've assessed them and we agree that there is some need for concern, the next step is for a urologist to organise for a patient to have an MRI scan. Now, the prostate MRI scan has become a critical component for our diagnostic pathway. It gives us an accurate assessment of the prostate size, which can impact on the treatment options, but it also gives us an indication of the anatomy of the gland that might affect the conduct of the surgery if we're going to go down that path. It also, most importantly, tells us, are there any abnormalities that raise a red flag that there might be prostate cancer going on? And if there are red flags about prostate cancer being in there, we also ask the question, well, do we think that the cancer is contained within the gland and perhaps going out into through the outer covering of the prostate or into the adjacent structures like the seminal vesicles? And in the image down below here, this dark area here at the very bottom, this part here is the prostate here in a cross-sectional view. And you can see the dark area here is a fairly typical prostate cancer. You can see the asymmetry where it looks quite bright on that side, but it's dark on that side. So looking for asymmetry in the images is a very important way in which we can help identify something going on. Now, one of the issues about MRI scans is that, I'm not sure if any of you have had an MRI before of any sort, you can just see here how tiny that little tunnel is. And I've had an MRI myself for my shoulder, and I found it very claustrophobic. But the good thing about MRI of the prostate is that because it's sort of feet in, your head, if you're tall enough, your head sort of sticks out and you don't feel quite squashed in. But that's something that we have to be cognizant about, is the fact that the MRI scan may not be for everybody. And as I was talking before about looking for signs of things, for example, with the prostate capsule, just think of a fruit like a peach or a plum, and you've got the skin of it, and that's like the capsule of the prostate. It acts as a barrier to stop things getting in and to stop things getting out. And if the cancer erodes that capsule, then it can, like here, it can go into the tissues surrounding it. Of other concern is the fact that you have the nerves that are responsible for sexual function that pass immediately adjacent to the prostate. And if the cancer can invade those nerves or penetrate the capsule and go into them. So we need to be able to get some sort of insight as to whether we think that is going on or not. Now, when it comes to the next step after an MRI scan, if we determine that we should take matters further, we do prostate biopsies. Up until relatively recently, the prostate biopsies were done almost exclusively using a transrectal approach. So you can see this needle here, where we literally pass the needle under ultrasound guidance and it goes through the front wall of the rectum to get into the prostate. And you can see that there's loads of bacteria in the rectum. So quite rightly, infection is a very serious risk when you use that approach. But the thing is that the infection risk used to be very low. But over the years, the bacteria are becoming more aggressive. They're becoming much more resistant to antibiotics. And we were actually losing that battle and being able to control infections after prostate biopsy. So rather than trying to chase it by developing more powerful antibiotics, we moved to the transperineal approach. And that is where we go for the skin. So the patch of skin between the back of the scrotum and the anus is called the perineum. And the needle literally punctures that and then enters into the prostate under ultrasound guidance. And with that approach, the risk of infection is almost zero. So following a transperineal biopsy, we give the patients a heads up. They're going to see, I actually tell them, you're going to see blood in the urine, and if you dare to look, you're going to see blood in the semen. And if you see it, I told you so. And I also reassure them that there's a tiny risk of urinary retention. And the best way to combat that is that we don't let them go home until they can do a pee afterwards. And as I mentioned before, there's almost a zero risk of infection. But something which is very interesting is that there's been some recent evidence that shows that if we do a huge number of biopsies, like you do it repeatedly on men over a number of years, that it could potentially impact upon erectile function, although we need a bit more evidence to absolutely confirm that. Now, if we do find cancer, the next step is that we need to do staging. We need to find out, do we think the cancer has spread anywhere? And the standard of care now is to do what's called a PSMA PET scan. Now, the term PSMA sounds very similar to PSA, but they're actually completely different proteins. So PSMA stands for prostate-specific membrane antigen, and PET scans, they're nothing new. They've been around for a long time, and it stands for positron emission tomography. Now, the PSMA PET scan, that's what's new, because there used to be just one type of PET scan, but now there are different types of PET scans which are specific for different types of cancers you're looking for. And how the PSMA PET scan works is that prostate cancer cells tend to have a lot of this PSMA protein on the surface. And we can actually target that. So we can actually inject a radioactive compound into the bloodstream, and it travels around the circulation and hones in on those cells and lands on them. And if we do put them through a scanner that has very sensitive gamma cameras, they can pick up the signals. And so it's a very clever way of looking for signs of cancer spread. And this is sort of fancy sort of imaging. It's really high tech, and it's extraordinary how things have changed over the years. This particular scan actually shows that there's lots of lymph glands involved, and so this is a patient we probably wouldn't offer surgery. So if we get to the stage where surgery is recommended, well, what do we do next? Well, we discussed the nature of the surgery, I'd just like to preface that I do accept there are other options, but I'm just talking about the surgical pathway. So we'll assume that the patient's considered all the other options. And so if surgery is the way in which we're going to head, we need to discuss the nature of the surgery and the risks of the surgery, and also manage expectations. Now, the type of surgery we do nowadays is what we call robotic surgery. It's a real misnomer because the term robotics implies a degree of automation. It almost implies that the surgeon sort of hooks it up, then presses the button, and then sits down and have a cup of coffee and reads the Sydney Morning Herald while the machine does everything for you. But it's not quite that way. So what actually happens is that we have this robotic platform with these arms, and you can see these robotic arms in this video. And these arms will feed long instruments down through these small holes made in the abdominal cavity. And at the tips of these instruments, you have these, you can see how you've got these various different types of instruments that can be controlled. And we control these through a remote surgical console. It's usually located in the corner of the room. And you can see with the hand movements there, and the hand movements are replicated by the instruments that are deep inside. Now, in reality, you could actually have that, rather than having a surgical console in the corner of the room, you could actually have that console, halfway across the world. You could have it over in Dallas, for all we know. But the only problem is that you've got to make sure you've got a darn good internet connection, and some people would argue we don't always have that. So that's something to bear in mind. And this is just a few pretty pictures of what happens with the robotic surgery. You can see how the instruments there are being used. They're literally like my hands. And you can see that you can very accurately get into the right planes. You've got beautiful vision down in very deep, dark holes of the body. So the video on the left-hand side is just going down the right-hand side of the prostate. And the video on the right-hand side is going down the left-hand side of the prostate. And you can see how you can use cautery to seal off some blood vessels while you're at it. But if you get into the right tissue planes, you can see they're actually bloodless. You don't have any bleeding at all. And it's fantastic where you can actually even do suturing with it. So you can grab these special instruments, and they're just like needle drivers that you have in your normal operating. And you can see how I can actually swing a stick. This is what a suture looks like. It's actually a curved needle, and it's curved because you can rotate it around. And then we can actually tie knots, So it looks, it's actually quite a lot of fun. It's sometimes you feel a little bit guilty. You're operating at the, and enjoying yourself at somebody's misfortune. So you do feel a bit guilty at the time. But having said that, I think you'd all agree, I'd much rather have a surgeon who actually enjoys what they're doing rather than somebody who's hating their job every day. And here you are, you can see we're tying a knot there. And you can actually use the instruments to actually snap the suture. So that's just to give you an example of the sort of fun we have. And when we do a radical prostatectomy, you'll see that on the top image here, there's the prostate. You can see the dotted line. If you look very carefully, there's a dotted line. And that sort of more or less outlines the what we're actually going to excise. And then the bladder is rejoined to the urethra. Just take a little note. If you look here, you can see that how there's a line here between the prostate and the rectum. And I'm going to show you on the next image the significance of that. So in the groove between the prostate and the rectum are these very important nerves. We call them the cavernosal nerves. And these nerves play a very important role in erectile function of the penis. Now, it's very interesting how the nerve supply to the penis is actually, all over the place, in that this nerve only provides the signal to give an erection, and it has nothing to do with the signals necessary for an orgasm, and also the signals necessary to have pleasurable sensations. So therefore, it is possible to have a pleasurable orgasm in spite of having a flaccid penis. So if you look at the anatomy here, you can see just how close those nerves are to the prostate. and that explains why erectile function can be an issue with surgery. So when we talk about surgery, we talk about the risk of bleeding and infection. The risk of bleeding, particularly with the keyhole types of surgery, has really fallen dramatically, and we're talking about transfusion rates of barely 0.2%. Risk of infection is probably less than 1% nowadays, and the reason is because we get patients home quickly. And so therefore, the moment a patient is well enough to go home, they go home, and being amongst your less virulent domestic bacteria at home is better than hanging around the more virulent bacteria that are found in a typical hospital situation. Now, the two big ticket items are urinary incontinence. Urinary incontinence is common, and I actually set my patients up to expect it. And so there are good ways to explain this, and the best way I find to explain is that you tell them what is the typical time taken to recovery is around about, say, 6 months, and you have them also expect they're going to need to use pads up until that time. You also need to. I also explain to my patients that they need to prepare themselves for the possibility it's going to take longer to recover. Might even take 9 months or 12 months. And they have to also prepare themselves for the possibility, prepare for the worst, that there's a possibility, maybe 5% chance it won't get better and resolve. But at the same time, we also can allow them to cross their fingers and hope that they might get a better than expected outcome, which is where they may not even leak a single drop of urine after the catheter comes out. And we see that happen. With erectile dysfunction, that is also a big ticket item. And a lot's going to depend on two factors. One is the age of the patient, and the other thing is that whether or not it is feasible or practical to perform so-called nerve-sparing surgery. Now, an often understated issue after surgery is the penile atrophy. So the penis, when it's unused, actually can shrink. So there are strategies to prevent it, but it's important that men understand that once it shrinks, you can't unshrink it. So it's important to get that to make sure we do everything possible to avoid that. Adjacent organ injury is a minuscule risk these days, maybe about 0.1, 0.2% risk. Now, rather than really being a complication, we also need to mention to our patients that there is a possible need for subsequent additional treatment, because the cancer may turn out to be more than what we bargained for, and there's a possibility they may need radiotherapy. So post-operatively, I let my patients eat and drink. We've got to get them up, get the whip out and get them mobilizing early. And we aim for discharge as soon as they get to a stage where what they're doing in hospital, they can do at home. And that's usually only 1 or 2 nights in hospital. They go home with a catheter, urethra coming out of the penis for 1 week, which is attached to a bag and a bag attached to the leg. Catheters removed in the office a week later, and they usually commence their penile rehabilitation and pelvic floor exercises a week later. Most men are able to drive their car within 2 weeks, so the recovery is is fairly quick. With the penile rehabilitation, that's a very important thing. It's believed to help bring forward and improve the chances of erectile functional recovery. But the other thing is it's also important to help reduce the risk of penile atrophy. There's a huge number of programs available, and one of them, I guess the commonest combination is using these so-called Viagra-like drugs, such as sildenafil's Viagra and tadalafil's Cialis. The good news about the latter is that it's just come off patent, which means that it's now very affordable. Up until recently, tadalafil was hugely expensive. And also using a vacuum constriction device, which is basically a penis pump. And usually I just get most of my men to acquire one through a adult sex shop where they're quite inexpensive, usually about $30, $40, or you can buy a medical grade device which costs between $300 to $500. Now, before I finish up, I just wanted to draw to your attention that the prevalence of erectile dysfunction in aging men is really high. If we all live long enough, I tell my patient, we're going to lose, as men, we're all going to lose it if we live long enough. And we never know when this is our last week before, you know, that our last week that our erectile function is going to be normal and we hit the downhill slippery slope, which is, you know, part of aging. And you can see here that if you're in your 70s, about 70% of men have some degree of erectile dysfunction, which can vary from minimal to moderate or complete, but that's a lot. Even in your 50s, look at that, almost 50% of men have a degree of erectile dysfunction. So therefore, after an operation, if you're about to enter your slippery slope to decline, the best you're ever going to get to is the degree to which it's declined, which would have declined over the same period of time after your operation. So that's something in terms of setting expectations realistically. But having said all that, it doesn't mean that we wouldn't try to preserve the function or to look at strategies to help men get back on their feet in that regard. All right, that completes my my presentation on the journey with prostate cancer, and we'll be taking questions a little later on, and I'm happy for people to be in touch with me if they've got further questions they'd like to ask directly of me.
Okay, thank you very much, Henry. That was excellent and extremely informative, and I think we're looking forward to a bit of a Q&A afterwards. Before we do that, though, I'd like to hand over to Emma.
Thank you, Diana, and thank you, Henry, for such an informative talk about radical prostatectomy. So I'll just share my screen. Oh, goodness. Okay.
Emma, just...
So, yep.
I think before we actually could see the entire screen.
Oh, you can't now?
Well, we can see your slides, but we can see a bit of writing as well. So maybe, yeah, that's better. Fantastic. Perfect, thanks.
Okay, I'm just going to lose my notes in this view. So anyway, we'll go with this view. With this webinar series, I'm just going to go through today a little bit about how we can help in terms of integrative oncology, what integrative oncology is, what acupuncture is, what some of the other modalities are that are involved in integrative oncology for prostate cancer care. And I'm also just going to share a snippet of my research, which is about trying to improve erectile dysfunction after radical prostatectomy, and also my interest in modifying a specific patient-reported outcome measure so that we can further understand the patient experience, and we can capture some clearer data in this field, which can then go on to inform better care or maybe adjuvant treatment for prostate cancer patients after radical prostatectomy. So currently prostate cancer is estimated to be the most common diagnosed cancer among men. And as Henry was mentioning, there are a few different pathways that after a diagnosis of prostate cancer that a patient may find themselves on. So sometimes it's a case of watchful waiting, sometimes active surveillance, radical prostatectomy, radiotherapy, chemotherapy, and androgen deprivation therapy. And as Henry mentioned, after radical prostatectomy, there is a chance that you may end up on one of the other, having one of the other treatments as well, such as radiotherapy. So I just wanted to introduce integrative oncology for prostate cancer. And the definition of integrative oncology is that it's a patient-centered, evidence-informed field of cancer care that utilises mind and body practices, natural products and/or lifestyle modifications from different traditions alongside conventional cancer treatments. And I think that's really important to just highlight that integrative oncology works alongside conventional cancer treatments. Integrative oncology aims to optimize health, quality of life, and clinical outcomes across the cancer care continuum, and to empower people to prevent cancer and become active participants before, during, and beyond cancer treatment. And I've just highlighted a couple of words there because I think it's so incredibly important to understand that the aims of integrative oncology, that the aims are to optimize health, quality of life, and clinical outcomes. And that's something that I guess I really am passionate about in terms of research, because quality of life is such an important thing, particularly in prostate cancer, where we have a lot of men living with prostate cancer. So some of the treatments available in integrative oncology are acupuncture, exercise, and mind-body therapies such as mindfulness. And I will just go through a few things where we can integrate those therapies to help with certain common side effects. So just to give you a little bit of background about acupuncture, acupuncture is part of the traditional Chinese medicine system, and it involves the insertion of fine needles into acupuncture points in the body. We use single-use pre-sterilized needles. A typical acupuncture treatment involves a consultation, then the insertion of the needles, and then a rest period of around 20 minutes where the needles are in retention. An entire consult lasts between about 45 and 60 minutes. Many of our patients report feeling very relaxed, and it should be an enjoyable experience. And contrary to what people may think when they have treatment, whether it be acupuncture or electro acupuncture or acupressure for prostate cancer, the needles don't go into anywhere terrible. They just go into, distal points. So it's nothing to be concerned about when contemplating whether acupuncture could be an option for you. We also have acupressure, which is derived from acupuncture, and it's just using finger or elbow pressure onto the acupuncture points. And sometimes we use press balls, which are just a tiny gold ball on a sticky plaster. And they stay in situ on the point. They're non-insertive, and often they can stay on for 24 or 48 hours. And then the patient or carer or support person can take them off. So what do we know about acupuncture? And it's something that I get asked so often is, how does acupuncture work? So the research tells us that acupuncture has multifactorial effects in the body. We know that it has a balancing effect on the sympathetic and parasympathetic nervous systems. And we also know from research using functional MRI that when we do an acupuncture treatment, that different brain centers, including somatosensory, prefrontal and insular cortices, hippocampus and hypothalamus, are stimulated to produce release of things like serotonin, opioid peptides. And we also see that we can get an improved blood flow through the area through antidromic axon reflex releasing neuropeptides such as calcitonin gene-related peptide. So some of the things that our prostate cancer patients seek help for are things like chemotherapy-related fatigue, chemotherapy-induced peripheral neuropathy, side effects from androgen deprivation therapy, including things like hot flashes, weight gain and reduced muscle mass, anxiety, and as Henry mentioned, the two big ones of urinary incontinence after radical prostatectomy, and changes in sexual function after radical prostatectomy, including erectile dysfunction, climacturia, which is one that is not mentioned a lot, but is when you get a leakage of urine during orgasm, dry orgasm, and infertility. And so as some of the research that I've come across suggests it's quite hard to find out the true statistics of particularly urinary incontinence and erectile dysfunction. But from the research that I've done, there's an estimation range of 14 to 90% for erectile dysfunction after radical prostatectomy, and between 2 and 6% prevalence of urinary incontinence. But as I said, it's actually very hard to glean the true rates. The good news for incontinence, as Henry's mentioned, it's improving, and a multidisciplinary approach, often with some inclusion of pelvic floor muscle training, can be really helpful. So to go through some evidence-based protocols in a bit more detail for some of these common side effects. We know that chemotherapy-related fatigue is a common side effect from chemotherapy. And the thing about chemotherapy-related fatigue is that it is persistent despite rest. So some research has shown that acupuncture has a significant effect in fatigue patients, and a meta-analysis indicated that acupuncture could significantly mitigate chemotherapy-related fatigue compared to sham acupuncture or usual care. And they used a regime which was acupuncture for 20 to 30 minute sessions 3 times a week for 2 or 3 weeks, twice weekly for 2 weeks, and weekly for 6 weeks. And it had a substantial effect on reducing cancer-related fatigue. Acupressure has also been shown to reduce chemotherapy-related fatigue. And I found this has been especially helpful because it's something that we can teach patients. So it's something that, particularly of late where there's been a lot of telehealth consultations, that we can actually teach patients the acupressure points. We can teach support persons or carers how to apply things like press balls, or how to apply the pressure with elbows or their thumbs. And the protocols really do help. Another one which is really common is the side effects associated with androgen deprivation therapy. And it's pretty interesting, the research in this area, because it's showing some positive effects. And just looking into the mechanisms, which I found really interesting, was that we've known already that acupuncture has an effect on brain centers, and there's some research to suggest that perhaps this is implicated in temperature regulation, and this is partly how acupuncture is helping to mitigate this side effect. Acupuncture also regulates serotonin and noradrenaline activity in the central nervous system, which again potentially has an effect on thermoregulation, and also that acupuncture has an effect on calcitonin gene-related peptides, which may also be implicated in the reduction of hot flashes. So the studies show that acupuncture has a positive and, importantly, a lasting effect on ADT-associated hot flashes, with significant reduction in the hot flash score and the daily hot flash frequency. So after the first 4 weeks of biweekly sessions, 41% of patients reported a reduction in hot flash score. The other important thing to note as well in this area is that exercise has been shown to help with weight gain and reduce muscle mass during treatment with ADT. And we have some great exercise physiologists who would love to see anyone who is seeking treatment down the exercise path. Anxiety is just a common feature across the prostate cancer journey, and is one that commonly will affect quality of life. And I found that a pilot and feasibility study of men using mindfulness have demonstrated significant decreases in prostate cancer anxiety and uncertainty intolerance, and significant increases in mindfulness, global mental health, and post-traumatic growth. So some really positive outcomes in terms of using mindfulness with anxiety. And I mean, some patients report feeling really relaxed after acupuncture, but doing some research, there is not much research to really substantiate, you know, that why that's happening or why that's being reported. So chemotherapy-induced peripheral neuropathy is also really common, can occur during or after chemotherapy. And so far, some small studies report that acupuncture for chemotherapy-induced peripheral neuropathy is safe and can have beneficial effects on associated symptoms. Electro Acupuncture, which is a real interest of mine, I'll chat about soon, is also sometimes used for chemotherapy-induced peripheral neuropathy. And it involves putting a low frequency current through the acupuncture needles. And the studies, again, they're early studies, but they suggest that electrical stimulation may promote functional recovery of the nerves through promoting blood supply and facilitating an optimal environment for the nerve axons to regenerate and grow. So, as I said, my electroacupuncture is a bit of an interest of mine. And just to give you a snippet of my research, is that basically my aim is to try and improve quality of life for men after robotic assisted laparoscopic prostatectomy. I guess because I found that erectile dysfunction does affect quality of life, and it is as Henry said, a bit of a red flag after radical prostatectomy. So what I really want to do in my research is to better understand the needs of men going through the prostate cancer journey and their experience. And to do this, I am looking at creating or modifying a specific patient-reported outcome measure so that we can not just build a better foundation for furthering research and getting clear statistics, but we can also really have a way of understanding the needs of patients and their experience during prostate cancer diagnosis and treatment. And I'm also planning to run a randomized controlled trial and feasibility study on electroacupuncture for erectile dysfunction after robotic assisted radical prostatectomy. And we just want to have a look and see whether this is a feasible treatment intervention that could be used alongside current treatments. So just carrying on from also what Henry touched on about the treatments available, and I would just say if there is anyone on the rehabilitation journey, it is a slow journey. It can take time, it can be a frustrating journey, but I would really encourage anyone who is in this phase to really persist with the treatments available because they do show benefit. So the main ones are the PDE5Is, there's also the penile injection therapies. All of these have varied uptake, and my research shows that a lot of people do stop the rehab because of barriers to continuing, but they really can be helpful for the long term. So the other ones, the vacuum erection devices, pelvic floor exercises, and as a last resort, there is available a penile prosthesis, which has good satisfaction rates, but is has high intervention. So it is a last resort. So in looking at all the therapies available for rehabilitation, it really got me thinking as to could we do more? Can we do something else for erectile dysfunction after radical prostatectomy, because it is associated with reduced quality of life, and not just for the men who are going through it, but potentially partners, family members. So for this reason, I really started to to further research what could we do. So I was involved in a systematic review with some colleagues in Beijing, and we found that acupuncture had a beneficial effect on erectile dysfunction when used as an adjunct therapy to pharmaceutical interventions, but really more quality research was required. So what I started to think was, could we use electro acupuncture to try and stimulate some of that nerve recovery to promote recovery of the nerves responsible for erectile function, so that we could also look at improving quality of life. So some of the things we know about electrical stimulation is that it increases some of the neurotrophic factors, including the brain-derived neurotrophic factors, nerve growth factor, ancillary neurotrophic factors, and that these neurotrophic factors are involved in the upregulation of cyclic adenosine monophosphate, which promote the expression of factors that are implicated in nerve regeneration. And so the short of it, just sort of in a simple form, is that electroacupuncture may, or electrostimulation may, help the growth of the axons across the gap site. It may help with sustaining the regenerative capacity of neurons over time. And also it can, if administered early, may make use of the limited time available for the Schwann cells to be active in keeping the nerve fibers alive. So I guess what I'm saying is that I'm excited to be able to look into whether we can use something like electroacupuncture to improve erectile dysfunction, to improve quality of life, and to use as an adjunct to treatments already available. And so just to finish up, I just wanted to leave you with a couple of tips for thriving with prostate cancer. I would really encourage you to talk through your options with your urologist, oncologist, GP, or integrative oncology practitioner. If you're in that rehabilitation phase, please persist. A urologist once said to me that recovery at that point is a marathon, it's not a sprint. So stick at it, talk to family and friends, and just check out these great resources, because Prostate Cancer Foundation Australia has great information available and it's very up to date. And also Beyond Conventional Cancer Therapies has some fantastic evidence-based information and is very comprehensive and very accessible. So thank you for joining us, and I will throw back to Diana to talk through any questions that might have come through.
Okay, thank you, Emma. That was very interesting, especially getting a bit of an overview what sort of symptoms might arise for patients, and some of the integrative and complementary treatment options that we have to address these. Now, we do have a question here, and that is, can acupuncture be given during chemotherapy? So I think that one's for you, Emma.
Acupuncture can definitely be given during chemotherapy. There is probably good to have discussion around what the optimal time points for the delivery of the acupuncture would be, and that would really be dependent on perhaps what type of chemotherapy you're having, what day you're having it, what your tolerance is, if you're having sort of good days or bad days after chemotherapy. But yes, to give a short answer, yes, it's definitely safe, and it's something that we do.
Okay, thank you. So I'd like to encourage people listening in, if you do have questions, please type them in the Q&A box or the chat box so that we can answer those. One thing that might be of interest, so I'll put the question out there to the both of you. Just in terms of the timing, you know, when someone gets a diagnosis and then moves on into the treatment phase, I mean, how does treatment such as a surgical approach and treatment such as the integrative approach? How does that sit together in terms of timing? You know, when would a patient be speaking to a surgeon? When would they be speaking to an integrative oncology practitioner? How does that sort of fit in on a time scale, I suppose?
Well, I guess traditionally the integrative oncology experts tend to get involved fairly late in the piece, and there's clearly, you know, it's clearly worthwhile doing some research to see if there's any benefit from earlier intervention. And certainly from Emma's presentation, which, you know, really impressed me, that there seems to be some very good signals for therapeutic signals from quite a number of early phase studies that suggest that further work should really be done. But one of the things which is quite different about prostate cancer and other cancers is the fact that it's fairly slow growing compared to the others. So when we talk about an aggressive prostate cancer, that's actually moving at a snail's pace compared to some other cancers like pancreatic cancer or biliary duct cancers. And so we actually have got the luxury of time for men to do their research and have a think about how they'd like to approach things. So after a prostate cancer diagnosis, it is, even for the high-grade cancers, a delay of 3 months is highly unlikely to cause any issue. And untreated, even the most aggressive cancers, if you don't treat them at all and leave them into their own devices, it's very high probability they'll survive quite a number of years before the cancer led to their demise. So you can see that it shows that we've got quite a bit of fat in the system.
Okay. Emma, what are your thoughts on that? I mean, from your perspective as an integrative oncology practitioner, what, I guess, would be the ideal time point for you to be seeing a patient with, you know, who has a prostate cancer?
Yeah, so I think, look, it's probably in reality true that integrative oncology, we get involved a little bit later in the process. And I think it's really important for us to understand what the diagnosis has been, what the treatment involves before we start to use things like acupuncture or exercise physiology or mindfulness. So I think getting involved is actually a little bit later is actually very appropriate, because we need all of that information before us. And we also, I guess, ideally, you know, we would have some communication with the team that's already been established as their primary carers, so that we can communicate perhaps treatments that we're doing, or you know, convey any changes. Or so I guess, look, it is true we get involved a bit later, but I think it's actually a great approach, because it means we have the information in front of us, and I think that's where we do our best work, really.
Okay, thank you for that, Emma. So in the meantime, we have 2 more questions. I think one of them would probably be a good one for Henry. What are the recommendations about checking PSA for men without symptoms?
Yes, look, there has been a lot of debate over whether we should be doing PSA testing or not. But I think that many of us can sense that it seems to have quietened down a fair bit in recent years. And a lot of it's got to do with the fact that longer term randomized controlled trials are demonstrating that very much in favor of actually performing PSA testing. And the other issue that resulted from PSA testing was that, well, we run the risk of treating all these men who never needed to be, that we might do more harm. But we have to acknowledge that there's been significant change in that we no longer operate on men with low-grade cancer. We're much more particular about who we test and who we treat. So that's made a huge difference. As things are at the moment, well, we don't think of PSA as being a test for cancer. We think of PSA as being a risk assessment tool. So the Urological Society of Australia and New Zealand recommends that men have their first PSA blood test at the age of 40. Now, we're not expecting to find cancer, but at age 40, it's a very useful triage tool, because if the PSA is below a certain threshold, which is known as the median PSA for the age group, then you can make a strong argument these men don't need another test for another 10 years or more. In fact, the chance of them never getting prostate cancer is very low. Whereas those men who've got a PSA greater than, say, 1, now it doesn't mean they've got prostate cancer, but there's a little bit more of a red flag, and they should perhaps have yearly testing. So it's a much more nuanced sort of discussion, in that it's not just simply get a PSA test to check for cancer. It's actually been used as a risk assessment tool to help us understand who's more likely to develop in the future, and who's more likely to have it.
Okay, thank you. That was a very comprehensive answer. Good to know, actually. Thank you. So I think we're kind of coming up towards the end of our session. There is one question that has popped up in the meantime. I think we might just answer that one before we conclude our session. So this is someone who's had a radical prostatectomy, then radiation and ADT, and has developed some cystitis and bleeding events, and has also ongoing problems with continence control. So the question is, you know, in a situation like that, what to do next, where to get help, how to move forward. Do you have any recommendations, maybe just in general, for patients who are having ongoing symptoms after the primary treatment?
Yes, this is of course always disappointing to hear when any patient is unfortunate enough to develop, I guess, adverse events from all of the treatments. Even the simple androgen deprivation therapy treatment, as has been discussed, has its own side effects. But the thing is that there are treatments that are available, and I guess that it's important to specifically raise these with the specialist as to what can be done. Just using one example, for example, recurring problems with radiation cystitis. Many of those patients will benefit from what we call hyperbaric oxygen treatment. So they basically go into a diving, like what the divers go into to prevent the bends, and they can go through a treatment course like that. Unfortunately, with erectile dysfunction, particularly if men are on androgen deprivation therapy, it's very difficult to reverse that because of the, I guess that one of the big ticket of items with ADT is that it is going to result in erectile dysfunction for most patients who go on that treatment. But if I guess the thing which has been the saving grace for most men is that it wipes out libido so much that most of the men are less fussed about having erectile dysfunction. But the other thing is that sometimes libido is preserved to some degree, and that creates more of an issue. Now, in some of those men, selected men, they may need to talk about the option of whether should they be considering a penile prosthesis. But another thing which is often forgotten about is that I've seen a number of men where they become very focused on one aspect of their adverse event, and tend to, I guess, channel all their energy into that one complication where, and this is where I think the psycho-oncologists form a very important part of the overall management. And I think it's very worthwhile for men who are really struggling to see a psycho-oncologist. These are psychologists who have expertise and experience in managing patients going through a cancer journey.
Right, thank you. Emma, is there anything that you'd like to add from your perspective in terms of the service offer here?
Yeah, it becomes a difficult situation, and I guess in terms of when things are quite complicated, I guess I've found that acupuncture just in terms of reducing some of the load on the nervous system to just induce some relaxation and sense of well-being is a really good place to start. And I'd reiterate, what Henry said just about seeing a psycho-oncologist to just maybe talk through some of those things. And I think that's a big thing, to just be able to have space to talk, to be honest about what the challenges that you're facing are, and to have that space to really explore perhaps, treatment options in terms of things like integrative and oncology, whether we can help. And certainly, I know myself, I'm always happy to talk to people in situations like that to just see if there is anything that we can do to help. So I guess it's a really case-by-case basis, but I think the big thing is to just, talk, to get help when you need it, and to get some support, that, try and reach out for support, and contact us and see if we can, work out if there's a sort of integrative approach that could help.
Okay, thank you very much. So I hope that provided a little bit of practical advice as to how to move forward if you are still experiencing symptoms a while after treatment has ended. Yes, so I think, unfortunately, our time is up here today. So I'd like to thank the both of you very, very much for a very interesting and engaging session. And I hope that the people who have listened in have also found it useful. And yes, thank you very much. Have a good day. Goodbye.